Thank you, Dr. Faisal, for joining us. We are very delighted to have you among us. We'd like to know about your Challenge TB project.
Thank you very much. Challenge TB is a project which is funded by USAID, and it's a global flagship project of USAID which works on providing technical assistance on the different aspects of TB care, services and management. Tuberculosis, as we all know, that many of the countries of the world has a huge burden, including Bangladesh. And in Bangladesh, the numbers of the incidence of TB in the population, it's not going down, it has remained static, 221 per 100,000 population. Every year new cases are being added to this large cohort of tuberculosis patients. About 64% are male and 34% are female. This disease has been very much prevalent in the large cities where the population lives, many of the population lives in very poor condition, in a very congested condition, particularly in the slums.
What are the support do you provide to the government through this Challenge TB project?
So Challenge TB provides support to the government. The Ministry of Health and Family Welfare, the Health Services Division has a lot of health service delivery structure in the country, and one of them is to look after the tuberculosis, and that's called the National Tuberculosis Control Program, but in brief it's called NTP. So Challenge TB works with the NTP basically, but working with the NTP is not the end of it, because there are many other NGOs and many other private entities who also work with the government, and they are also very big players in the TB world. So Challenge TB, in short CTB, works with them, and in many cases also provides technical assistance to those NGOs as well as the private entities. There are three areas of this support. One is to improve the accessibility of the TB infected persons to reach out to the services, to reach out to the diagnostics and the treatment services. The second one is to stop the transmission. I mean, the disease, the tuberculosis as the disease would never get contained if it is not, the transmission is not stopped. So that means we, in the general population, there has to be prevention approaches as well. And the third one is to strengthen the different service delivery platforms. So the existing in the country, the government has set up a lot of service delivery facilities, diagnostic facilities, treatment facilities. So Challenge TB is working with those facilities in strengthening their capacities, in strengthening the quality of services. So on those three aspects, Challenge TB is working. And this is our last year, the final year of the project. It has been a 5-year project. So we started about 4.5 years back, and we will be ending in June 2019. Through our support, there have been very specific, visible things that have happened in the country. Number one to mention is the establishment of a biosafety laboratory level 3, which is a very high level laboratory where the TB, the bacilli could be tested, could be incubated, their culture sensitivity could be tested. So this kind of a testing laboratory is the first of its kind in Bangladesh, and it has been set up in Sylhet.
So it's only in Sylhet?
That laboratory is only in Sylhet. I mean, that kind of a laboratory of that level is only in Sylhet. And within the government, the NTP system, that is the only laboratory which has been set up with USAID money. CTB has helped, and it's a containerized. I mean, the beauty of this laboratory is that the laboratory was built in South Africa within few containers, and these were shipped directly from South Africa and brought to Chattogram, and from there it has been taken up to Sylhet, and there these were just placed on certain pillars and certain mounted areas. So in a way it's a full laboratory which has come intact. So nothing had been put here in Bangladesh except the electric connections and the water connections. Those were put here. The second one, which is a very visible support that has been provided, is setting up a specialized child TB center. Again, in children, tuberculosis detection is very difficult. And it is because the children, they cannot give the sputum, which for the adult is easy to obtain. So therefore, for children to obtain sputum, some other different mechanism has to be done, and the children has to be handled with care. So in the country, the first specialized child TB center has been set up in Dhaka Shishu Hospital, and government is planning to set up this kind of specialized children TB center in other parts of the country.
So when the center in Dhaka Shishu Hospital will be operational?
Oh, this is already in operation. It was
since how long?
It started in November 2018. It was set up in the early months of 2018, and then it became officially opened up in November 2018. So it's now functioning. So a lot of the children with tuberculosis, with presumptive tuberculosis, are being referred from other parts of Dhaka city as well as from outside to this particular Dhaka Shishu Hospital, where they can diagnose, they can identify that which child is tubercular, and then the treatment is given. The third thing that we have, Challenge TB has been able to provide support is to provide a gene expert machine. This is a machine which can finally diagnose a patient having a tuberculosis or not. For tuberculosis diagnosis, sputum test, X-ray, some blood tests are the only things that can be done. But for getting a confirmation, there is one machine called the Gene Expert. It's not a big machine, it's a small machine. But again, this can identify the tubercular bacilli very well. Even when the tuberculosis is not in the lungs, it is extrapulmonary tuberculosis. Those can also be diagnosed properly through this Gene Expert. So in the country now, 193 plus 33 machines are now in the process of being set up in different hospitals and different places, including Upazila health complexes. So out of those 39 machines were the first ones which were given by the USAID through Challenge TB.
So before the intervention of this project, there was no
Gene Expert machine. There was no Gene Expert machine. And along with the Gene Expert machine, Challenge TB had been also been able to connect all of the Gene Expert machine through internet That's called the GX alert. So in each of the machines which USAID has funded through us, we have been able to connect them, and these can be, from Dhaka, this can be seen that which one is functioning and what are the problems in different machines. So GX alert is an application which can be used with the Gene Expert machine, and then that can give us the real-time situation of all the machines. Unfortunately, the government, beyond the 39 machines, the government, they have procured a lot of other machines, but they have not procured yet the GX alert, that application, that software. So we are trying, and we are advocating that this software should be put in place, and if that is in place, then they will be able to see by themselves every day that how the Gene Expert machine of the different places are functioning. The next support that we have provided, and that is going to be established, that for identifying presumptive possible person with TB cases, there are approaches, there are methodologies, and that needs to be utilized. And in those methodologies, applications are there, apps are there. So making the approaches more digitalized would actually help the providers in identifying the cases quickly. And so for adult TB, there is an apps. Adult TB screening, there is an app. For the child TB screening, there is another app. So with those application of those apps, the possible persons having TB, persons having possibly TB could be identified quickly. Because one of the approaches for addressing the tuberculosis is to find out the cases as soon as possible. And if they are diagnosed finally to be a TB patient, they should be put on treatment. Because if that could be done as soon as possible, then the transmission is halted. The last support that we have provided, and yet the government has not started it, that is the TB patient in a family. Wherever there is a TB patient, there are other contacts in that household, the brothers, sisters, wife, husband, mother, father. So immediate household contacts, those need to be tracked down, and they need to be provided with a preventive therapy. The drug that is used, rifampicin and isoniazid, in abbreviation it is called 3HP. So the 3HP drug, this has not yet been brought in the country by the government. Challenge TB has done a demonstration project administering 3HP to about 1,000 contacts, and so that the results and the report will be coming out in March, April. So based on that result, government has already said that they would be procuring the drugs, 3HP. And the one interesting thing is that none of the drugs, except one or two, most of the important drugs for tuberculosis treatment, these are not manufactured in Bangladesh. These are mostly brought from outside. So that is something which again the government has to take some proactive step, and so that the drugs could be manufactured here with high quality, and that could be given. And again, the TB treatment throughout the country is free. Government has committed that all TB treatment would be free. So there is a huge commitment of the government to provide TB treatment, and Challenge TB is supporting all those commitments in strengthening the system, in providing new approaches, in setting up new technologies, so that in the future government will be more efficient and effective in addressing tuberculosis.
I don't know why the name of your project is Challenge TV. There are many challenges.
Challenges.
And, Bangladesh is a country where TB is prevalent for very a long time. So with the huge TB burden and every year the numbers are adding up, what is the current situation even after the 5 years completion of this project, where we are standing now with this TB cases?
Thank you very much for this question. With the TB situation, we have not been able to bend down the curve. Means that the curve has been in a plateau form for many years. Currently, the incidence is 221 per 100,000 population. 11% of them they die, so that means about 59,000 people every year they are dying of tuberculosis.
Are these the real numbers or the
projection? No, these are real numbers. These are real numbers because some TB surveillance is there, and the annual.
I wanted to mean that is there any possibility that the actual numbers might be higher than undetected or?
Oh,
like
certainly. I mean. The numbers which I have just now stated, there are missing cases, because even with that 221 per 100,000 population, it is said that only we are reaching to 68%. We could find 68% of cases. So 32% of the cases are missing. And now many of the missing cases are among the children, first of all. And secondly, many of the cases are extrapulmonary, and so those are not detected very easily. Extrapulmonary cases can be detected, whenever there is a disease of something else and that's not being cured, and ultimately the doctor thinks that probably there is a TB infection. There are other issues are related to the not finding the cases. There is one other issue that at one time in the past we used to know that if someone has a TB, that person would die very soon. But nowadays it is said that if you treat the TB, you would get cured. So there is a consolation factor there. People think that, okay, if I'm having TB, tuberculosis, I will go to the hospital, I will go to the clinic and get it confirmed, get it diagnosed, and then I will take the drug, and the drug is free. So after taking the drug, I would be treated very well. So there is a reluctancy among the population to go and get the diagnosis and then start the treatment. In many cases, the treatment was started but not completed. And many of these non-completion of treatment cases are turning into multi-drug resistant tuberculosis, MDR-TB, and that's also increasing. And that is going to be a much more bigger problem in the country. If, in the coming years, the number of multi-drug resistant cases increases, then the cost of those treatment of those cases by the government would be very huge, would be so big that the government would not be able to treat all of those cases. But if those cases are not treated properly, then they keep on transmitting. And their transmission probably would be that the new TB case would be, from the very beginning, probably would be an MDR, multi-drug resistant case. So,
I think, to prevent this, theoretically, the DOTS program were introduced. So,
right.
Would you like to say that these programs are not getting enough traction to prevent TB cases?
DOTS is spread out all over the country, and the DOTS centers, most of the DOTS centers have diagnostic facilities as well as the treatment facilities. But as you said, yes, I mean, they are not very prominent, they are not very visible, and the people doesn't have the awareness that for the TB treatment, they should go to those dot center and obtain the free treatment. So definitely awareness is a big factor for all of the aspects. Starting from the diagnosis, starting from the going to the hospital or the clinics for getting themselves identified and diagnosed, and then starting the treatment, the people are not fully aware of it. Many of the patients, most of the patients I would say, that they have the coughing as the predominant symptom, and coughing, it is said that if it is more than 2 weeks, anyone having coughing for 2 weeks should go and get it tested. Other than that, having low-grade fever, night sweats, losing body weight, not feeling well, all of these combined are the signs, symptoms of the tuberculosis disease. But in case of extrapulmonary one, these classical symptoms may not be there. So without the classical signs, symptoms, the person can have tuberculosis. The challenge TB, I mean, there has been some other activities, some kind of a research-based activities. One of them is helping the government identify the most high-risk areas where the TB patient could be numbers are more than the other areas. In Dhaka city, there are many wards. Not all of the wards have the same number of TB patient concentration. So with Johns Hopkins University, they have a methodology of calculating that these different wards, what could be the proportion of TB patient in each of these wards, and they call it that identifying the hotspot areas, so that in those particular wards, the efforts, searching the patient, preventing the transmission and treating the patient, so those things could be intensified in those particular wards. So we have done the Dhaka South City Corporation hotspot mapping and have given this to the government. The National Tuberculosis Program have said that they will use it, and they have shown keen interest in using it, so that the intervention in those particular hotspot areas could be intensified. We are now starting to do the hotspot mapping in the Dhaka North City Corporation. In the cities, in the large cities, worldwide, there is an initiative which is called the Zero TB Cities Initiative. In Bangladesh also, the government has embraced this initiative. Means that in the large cities where the population congregation is much more than the rural areas, where the environment is not that congenial, and where the transmission of the disease is more, government should put their efforts in those places. And so that Zero TB Cities Bangladesh, the declaration by the then Health Minister, Mr. Naseem, was signed on 28 October 2017. When the Zero TB Cities Bangladesh, that strategy was adopted, following that an action plan has been developed, and so now all the future strategies and the programs and the plans which are being developed by the government, government is taking that strategy as their basis. But that doesn't mean that the TB activities, TB intervention would be stopped in the rural areas. In the rural areas, that would continue. All over the country, this would continue. But in the urban areas, it would be more concentrated, and we need to concentrate our effort. The donors also agree to it. They are also planning to invest their resources, their support. and we hope that this strategy would help the government in making the cities free of tuberculosis.
So what are the main areas in overall Bangladesh where the TB patient concentration is higher?
It is said Dhaka is one, Dhaka, Chattogram and Khulna. These are the three big cities, and within Dhaka there are two city corporations. So these four areas are said to be the highest one. Certainly in those places where, among the other cities, where the population is bigger and it is growing faster, industries are coming up, and people are migrating from rural areas to urban areas, all of those would become very vulnerable, and then they would, in all of those cities, government will have to start targeting their intervention. And again, for targeting the intervention, government has to draw up a very good plan. I mean, that is the future. Unless you can plan the future very well, it would be not worthwhile to invest everywhere. It is not worthwhile to spend your money just based on assumptions, because there are evidences there. So based on the evidences, government has to plan accordingly. And I said earlier that the MDR TB is one area which needs special attention. Government is trying to pay attention to the MDR TB, but the resources are not adequate, and as such, they have not been able to set up MDR TB diagnosis and treatment facilities all over the country. So there are now only 6 places where, including the National Institute of Diseases of Chest and Hospital, NIDCH. Other than that, there are a couple of CDH, Chest Disease Hospital, and Chest Disease Clinics. So those 6-7 places are the ones where the MDR TB could be diagnosed and put on treatment. So there the government has to increase their effort.
So you said about the missing numbers, and I think these numbers are almost similar than that of the 1 decade ago. So what could we do to reduce these missing cases?
Worldwide, very recently last year at the UN there was a high-level meeting, and where heads of the states they assembled together to review the situation and commit that what they can do. So in that UN high-level meeting, UNHLM, they have committed that 2 things have to be done very quickly. One is finding out actively the cases as quickly as possible. So active case finding is the one of the strategies and approaches that has to be taken up by the government. And the second strategy is also a very important one, that prevention. The TB cases, wherever they are known to the government system. So if the household immediate contacts of that particular TB patient is taken into account and put on preventive treatment, then we can prevent TB transmission in a large population, in a large cohort, very quickly. Instead of waiting to find a patient and treat the patient, if we go to the active cases and get their household contacts and treat them preventively, that would be much more, that would give us much more results.
Do you think that Bangladesh have enough resources to address those 2 approaches in terms of diagnostic and treatment facilities?
Those 2 approaches, the resources that are available now in the country, we can get the results if the planning is done properly. The problem is that planning the activities, it by itself takes so much of time that we lose time and then we are nowhere. We don't find ourselves doing the work properly. With whatever the limited resources we have, I think the intention to do those two things should be put into action. I mean, if we keep on saying that we don't have the resources and as such we will not be able to do it, that would be a wrong approach. Whatever the resources are available, yes, we should start doing it. We should try to find out resources. We should try to find out external resources, internal resources as well as external resources. I mean, just to give an example, the DG, Directorate General of Health Services, DGHS, there are multiple operational plans. And one of the plan is the National Tuberculosis Program. But there are 11 other OPs where there are money available to address tuberculosis. But those money,
those areas?
I mean, like the NCDC, with diabetes mellitus, I mean, there is some money available that while testing for diabetes, the person should also be tested for tuberculosis. But that money is not utilized properly, so it is sitting there idle, or at the end it is used for something else. So if the money of all those 11 OPs are pulled together, then there will be a lot of money available for National Tuberculosis Program. So here you need to have advocacy, first of all. Second, you need to have a strong leadership so that these monies could be pulled together and put into use. Once, if you can pull all those money, then you can show the evidence that yes, I mean, I have tried and pulled the money from other sources. Let's go out and see that which other ministries has money. I mean, just to give an example, the Ministry of Local Government. I mean, they are responsible for the urban health, but they don't have the capacity to provide the health services. So what they do, they contract the NGOs to provide the health services. But they have some money to do the awareness raising activities, to provide support to the poor patients, to help the patient access the services. So they do have some money, but that money is not utilized for those activities. So the Ministry of Local Government and Rural Development Cooperatives, from their money could be channeled for the tuberculosis program. There are monies available with the Ministry of Social Welfare. Each of the big hospitals in Dhaka, they have a social welfare officer. And each of the officers, they have an allocation for providing support to tubercular patients. And hardly they ever provide any support to the tubercular patient. So if the monies from that Ministry of Social Welfare could be, brought into use, that would be something. Similarly, as I said earlier, the Ministry of Local Government, it's not only Ministry of Local Government, because Ministry of Local Government has the money, but again, the city corporations, which are all elected, the city corporation, they themselves have budget. And in their budget, very interestingly, for health, it's all lump sum. They don't specify that for health what they will do it. So if someone can help them that with that lump sum money on health, what can they do besides working on tuberculosis? So it's a matter of leadership, it's a matter of active, lookout that how you can do the work.
Your project is coming to an end, so if you can outline very briefly what were the major successes you have achieved and what were your most critical challenges in this 5-year journey?
I will talk about the challenges first. I think the biggest challenge is the bureaucracy of the government. And that we all know that the government has a lot of procedures and systems through which they have to function. And as they have to follow those procedures and their systems, sometimes time runs out and then it becomes very difficult to implement something. The second challenge is the changing leadership within the government. The government higher level officials like the line directors, like the director generals, they keep on changing. They are not static, and as such, a person who has been the line director for NTP and has been there for 6-7 months, and then that person gets changed. So it is very difficult for the new person to come in and pick up from where the earlier person has left. The third challenge is that the government has now a lot of resources. Although there is a limitation, but they have to do the resources. But the resources are not properly planned and not properly utilized. There is a delay in planning due to bureaucracy, and then there is a delay in release of money for the activities. So we have seen that the money is there for training, but as the time is running out, say they are unable to obtain that money and do the training. So then they go to the donors that if immediately some money could be made available, they can do the training. So the money which has been available in the government system, if that could be used, then probably it would not have been a problem of resources. The last challenge is the use of technology. Although the government, the Prime Minister, she has been trying to digitalize everything in Bangladesh and to have a digital Bangladesh. But I think at the level of implementation, digitization is a difficult thing.
So, coming to the successes of the project.
Well, the successes of the project, as I said, that we introduced a lot of the digital things. We established demonstration outlets, demonstration facilities like the BSL-3 laboratory, one of its kind in Bangladesh. For the tubercular laboratories, one thing has to be always kept in mind that the bacteria, the bacilli, could actually infect the laboratory people. So there has to be so much precaution that they should not get infected. And again, there is the WHO recommendation, and that we have started, and probably that would be also an example for the entire country. That is the screening of the healthcare providers, particularly in the hospitals and in the National Institute of Diseases of Chest and Hospital. NIDCH is a large hospital where TB patients are there all over the hospital. The nurses, the doctors, those who work, have never been tested that among them there could be some tubercular patients. So we have already initiated the process, and soon we will start the testing, because this year the World TB Day, the theme has been "It's time to know your TB status." So we want to show the government that the healthcare providers should be tested on a regular basis, and they probably would also should receive the preventive therapy, because that's the WHO recommendation. So that also that's also a success, that we have been able to demonstrate. Government has accepted it. Government is planning to start it all over the country, particularly in those places where TB patients they come, and those are being tested and treated. So the DOT center providers should be tested. The TB, chest disease hospitals and chest disease clinics, the providers of those places should be tested. One other, the achievement has been that we have been able to provide some psychosocial support. We have been able to demonstrate that the multi-drug resistant patients, because they have so much of psychological burden, their psychological condition is very poor. So they should be provided with psychosocial support. And so we are trying to integrate a psychosocial apps which can be used by the nurses as well as the doctors in working with the MDR patients, MDR TB patients, that whenever they are depressed or whenever they are not in a good position, they should work with that apps. And also that app has an indication that they should be allowed to do some handwork, some arts and handicrafts work. So the providing psychosocial support to the MDR TB patient, that is also the first time we have demonstrated it to the government. Government is willing to take that one, and we are hoping that at least in the NIDCH, the MDR TB patient ward, they would regularly use this app and the approaches. Counseling, they would do the counseling. Counseling is an important element, but all through the TB service delivery, counseling is not available. So we are trying to build up the counseling capacity of particularly the nurses, because nurses are the ones, those who are frequently coming in touch with the patients. So if the counseling could be done by the nurses, that probably would be of a great help.
So who are taking these initiatives of introducing these things?
The government, we work with the government,
okay,
and we train some people of the government to use
but
those.
do you think that after phasing out this challenge project, this will sustain among the
Okay, for that one we have done one thing, that is we have structured and developed a digital archive for the National Tuberculosis Program. So where all the training materials, where the manuals and the standard operating procedures, everything has been loaded there, plus all the apps. There are 6-7 apps. So all those are there, available, as well as the apps are available in the Google Play Store. So it's my strong belief that at least one or two of the apps would be utilized. Like one app which is definitely going to be utilized is called the Mandatory Notification app. Back in 2014, the President of the country has circulated an instruction saying that TB has to be notified. Wherever the person is diagnosed with TB, should be notified to the National Tuberculosis Program. But that system, that instruction has never been complied with. After working with so many years, this is now coming into reality that all the private practitioners and the government doctors, if they find a patient, a tubercular patient, they will notify, and an app has been developed, a very easy to use app, and that would be available in the archive as well as in the Google Play Store. And so we are hoping, now this is being validated with 500 physicians to see that how much this is being used. And so this is already taken up by the government, and so we hope that this will be continued. So at least out of those 7 or 8 apps, I believe that 2 or 3 of them would be in use even after we have shut down our doors.
Looking forward to the future, the scenario of TB and other issues, how do you see it? The numbers, the prevalence is, if it is still remains same, how long it may take to achieve the real progress. We have missing cases, we have resource constraint. So among these, do you think that there is a need of a robust investment or robust activities, program implementation?
Looking towards the future, as I see that there has to be actions not only in one area, it has to be a comprehensive attention toward the entire issue. And that is why for the cities particularly, we are saying that a comprehensive effort should be mounted, where the prevention, the treatment, the active case finding, involvement of all the sectors, the private and the public, involvement of the different ministries, stakeholders, that should happen. So we have, developed an approach called the chakra. This is a round circular thing. This one, the chakra, this has certain elements into it, and that these are all simple things. We are doing those things, but maybe not putting equal emphasis on each of the elements. So we need to put emphasis on each of the elements. That's number one. Number two is that with whatever the limited resources we have, we can work on this and put a very positive outcome. We can bring out positive outcome. The third thing is that the people themselves has to be more proactive. Means people participation. The people, they have to come out and they have to get themselves examined. They have to get themselves diagnosed. People participation is not that active. I think people's participation in every area is a critical element. If the people are positively involved in all of these activities, this situation would change. So people's participation, active collaboration, active engagement, that is required.
How it could be increased
It's through the, radical change possibly would not happen overnight. It has to be a gradual, incremental change. It should not be only the responsibility of the Ministry of Health and Family Welfare. Other ministries has to come and play their responsibility. As I said, the Ministry of Local Government. The urban health is the responsibility of Ministry of Local Government. But the Ministry of Local Government doesn't pay due attention to the urban health. They are engaging the NGOs to provide the services. The Ministry of Social Welfare, the Ministry of Communication. Different ministries has to put their effort along with the Ministry of Health and Family Welfare.
Have you ever worked with the Ministry of Education to put special emphasis in the curriculum and in the schools and primary and secondary schools?
We have not worked, but that's an area where, yes, from the very school age, if the people can understand about the signs and symptoms of tuberculosis, certainly whenever those kids would certainly be having those signs symptoms, they would go and positively see a provider and say that, well, please examine me and see that if I'm having TB or not. The social stigma is still there, so people participation would not increase unless the stigma is taken away. Still, if in a family a person gets infected, the stigma comes into action. The family members start looking at that particular person in a different way. So for that stigma, sometimes the disease condition gets hidden and the treatment is not properly done. So the perception, the stigma, misconception, those also needs to be addressed. And those could be addressed by other ministries like the Ministry of Social Welfare, Ministry of Education, Ministry of Women and Children Affairs. So that can be, so all of the others, this chakra tells that all different stakeholders, they should come together and work on it.
Okay. Thank you, Dr. Faisal, for your
It's
time.
my pleasure.